Renal colic. Scenario: a 47-year-old man presents to the emergency department with a 6-hour history of acute colicky loin pain, nausea, vomiting and hematuria. Introduction. The diagnosis of renal colic is not usually difficult. Typically there is very severe colicky pain radiating from the flank. Sensory nerves from the ureter and renal pelvis enter the spinal cord at T11, T12, L1, and L2, and pain is referred to these dermatomes. Stones can lodge in the ureter at the pelviureteric junction, at the pelvic brim or at the ureterovesical junction. The renal pelvis refers pain to the loin and back, the lower ureter to the testis or labium majus, and the lowest pelvic part of the ureter to the tip of the penis or perineum. Fig. 16. The priorities are to organize appropriate analgesia, confirm the suspected diagnosis of a ureteric stone and look for obstruction or infection. The possibility of an underlying stone-forming tendency needs to be considered after the acute problem has been dealt with. History of the presenting problem. Ask about the following. Radiation of the pain. Does this follow the pattern typical of renal/ureteric colic? Hematuria, present in this case. Passage of grit, gravel, or stones in the urine, which clearly would confirm the diagnosis. Fevers, sweats and rigors. Could there be infection, which with obstruction can be a very dangerous combination. Continued passing of urine. Bladder stones can halt urine flow suddenly, with penile or perineal pain that is sometimes relieved by lying down. The presence of hematuria in this case makes it nearly certain that the diagnosis is urinary stone, but if there is no history of blood in the urine and if the pain does not radiate in a typical manner, then consider the following. Musculoskeletal pain, not usually so severe, typically not associated with nausea or vomiting, may be exacerbated by movement, and the patient may be able to assume a comfortable position. Biliary colic, typically felt in the right upper quadrant and epigastrium, may be precipitated by fatty food, and is also associated with nausea and vomiting, a past history of indigestion, dark urine, and pale stools. Other relevant history. Has the patient had any similar episodes previously? Ask carefully about predisposing factors, family history, bowel disease, diarrhea, and use of antacids or vitamin D-containing compounds. Examination, general features. Once again, it is important to make an initial assessment as to how ill the patient is, but the details given here do not indicate that the patient is likely to be very ill. Note particularly the following. Evidence of infection. Is there a fever? Is the kidney tender? Are there any physical signs that might suggest a different diagnosis? In the spine and back, does movement exacerbate the pain? Is there local tenderness? In the upper abdomen, is there right upper quadrant or epigastric tenderness? Is this gallbladder pain? Investigations. Blood and urine tests. Urine dipstick. If there is not at least a trace of hematuria, then the diagnosis of renal colic is in doubt, and urine culture. FBC, electrolytes, creatinine, liver/bone function tests. Blood culture, if there is clinical suspicion of infection. Imaging. To confirm the diagnosis of urinary stone disease, to demonstrate the site of any stone, to detect evidence, if any, of obstruction and to look for the presence of other stones. Plain radiography. Ask for a radiograph of kidneys, ureter, and bladder, which should reveal radio-opaque stones, containing calcium and cysteine, but not urate. Ultrasonography detects all stone types and will demonstrate obstruction, but is often difficult in the lower ureter. CT or intravenous urogram defines the site of obstruction, and the stone is usually visible as a filling defect in the ureter. NB. Urate stones are radiolucent. Management. Immediate priorities. Give adequate analgesia and antiemetics as the pain of renal colic is very severe. NSAIDs such as diclofenac are often used, alone or with opioids. If possible, avoid NSAIDs if there is significant renal impairment. Maintain adequate hydration, if necessary with intravenous fluids. If infected, treat vigorously. Obstruction without infection. This is usually diagnosed when ultrasonography shows dilatation of the pelvic calyceal system, but there are no clinical or laboratory features to suggest infection. Stones smaller than 6 mm in diameter usually pass spontaneously, but stones larger than 1 cm will probably not. If the patient's pain is controlled and the stone is small, observe carefully. If there is no progress over a few days or if the stone is large, then the obstruction must be relieved. A range of techniques is available to urologists for this purpose: extracorporeal shock wave lithotripsy and endoscopic, percutaneous or open surgical removal, Fig. 17. Obstruction with infection. This is an emergency requiring urgent, same-day, relief of obstruction, usually by anterograde percutaneous nephrostomy, and broad-spectrum intravenous antibiotics pending culture results.